Hello and welcome to this lecture. This is the first lecture in a series that is intended to help with OSCE preparation. So we'll initially discuss who this is intended for, and then I'll explain how to do a pain management assessment for your OSCEs, which should nicely lead on to the next lecture. So this lecture is intended for early year medical students, and this is only meant to be supplementary to your normal studies. So please use this as a guide, but you will need to do a lot of studying around this um, to prepare adequately for your OSCEs. This may be students that are doing OSCEs for the first time, or if you just like a refresher on how to do pain assessments. So what do we mean by a pain assessment? So essentially, we're talking about Socrates. But it's not just a mnemonic that we need to discuss. When a patient says that they're in pain, that can mean various things, and lots of diagnoses are going to be going through your mind. And now you need to zone in and learn how to go from symptom to diagnosis. So, in your first and second year medical school, you're mostly going from learning what a pathology is. So, you start with the diagnosis and you learn what symptoms that diagnosis presents with. For example, heart attacks. What sort of symptoms do you get with heart attack pain? Now you're going the opposite way. Now someone is coming to see you with pain, and now you need to go from the symptom to the diagnosis. So Socrates is the tool that we're going to use to help you get there. But please, this is just a tool. You need to do the studies around different diseases to learn how to use this tool. But I'm going to do my best to step you through. So whenever someone comes to say that they're in pain, the first thing is, where is the pain? So the location of the pain is going to start giving you your differentials just from the first question. The reason being is you need to think about what organs are there and how they can dysfunction to cause the pain that the patient is presenting with. For example, if they come in with chest pain, you're going to be thinking of heart, lungs, musculoskeletal. Those are the organs in the area that can present with pain. Now, if someone presents with pain that's widespread, for example, they say that they have pain throughout their abdomen, you need to ask them if you can point with one finger to where the pain is worst, where would you point? And again, that should help guide you to differential diagnosis. So whenever someone says where the pain is, you immediately start thinking of the organs that are there. So next is our O in Socrates, and O stands for onset. So you want to know, what were they doing when the pain started? Was it sudden? Was it gradual? And what about any triggers? So for example, if they say that I've had a patient one time say that they were mowing the lawn and they had a sudden onset thunderclap headache. And they described it as they were just mowing the lawn and had a sudden pain that felt like someone hit them at the back of the head with a bat. That is a sudden onset pain. That is as opposed to gradual pain, when someone would say, for example, my chest pain started earlier in the morning and then started gradually getting worse throughout the day, and then I got really worried and now I'm here to see you. Making that diagnosis making that differentiation of whether it's sudden or gradual does make a difference to your diagnosis. Another thing is, what were they doing when they started? So this is important because it's related to triggers. So for example, if someone was getting sudden onset chest pain when they were running, then you immediately know that it's chest pain on exertion. That takes your diagnosis towards one particular angle. Another thing is when someone says a particular time, for example, the pain started at 3 o'clock, doctor. Your next question is, why do you know that time so specifically? Did something happen at 3 o'clock that reminds you of it? And again, that'll lead you more to know whether it's a sudden or gradual onset pain. Now, I'm a little controversial here. I usually from onset I go to timing. The reason being is I just find that in my history taking, this helps me flow, helps the history flow. When you when you continue to practice histories, you will get your own assessment style and you might decide not to do this. But this is just an example of what I like to do. So once we've gone through onset, how did the pain start? Was it sudden or gradual? And what were you doing when it starts? The next thing I like to know is the timing because I feel like that fits in quite nicely. So, for example, how long have you had the pain for? Now, if a patient says 3 to 4 months, for example, your next question always has to be, did anything happen 3 to 4 months ago that could have triggered this off? Anytime someone gives you a time frame, this should always be your next question. What were the triggers? For example, someone had a cough, right? So we're veering away further from pain now to other things that we can use Socrates for. And they say, I had the cough for the last 3 months. And you ask them, did anything happen 3 months ago that could have triggered this off? And they say, well, yes, doc, I went to holiday in Spain and we stayed in an Airbnb and the air condition was on. You're immediately starting to think down the path of Legionella and atypical pneumonias. So timing and triggers I find go quite well with onset. And then I usually go back up and continue on my Socrates. So now that we know where the pain is, how it started, and when it started, the next thing is, what does the pain feel like? Whenever asking this question, make sure you start with an open-ended question, which is just that. What does the pain feel like? Can you describe the pain to me? If the patient is and ahhing and a little uncertain, then you can offer, would you like me to give you some words that might help? Now, in an OSCE, the patient is already prepared to know what to answer this question, how to answer this question. In real life, they might need some examples, in which case you can say, is it sharp, burning, dull, ache, or crampy? To me, dull and ache very much are similar, but the other ones around it are different. And again, as you continue taking OSCEs, you'll ask this differently. But in the beginning, early stages, just open-ended, and your patient will be ready to ask with an answer for you. So after character, you want to touch on radiation. Where does the pain radiate to? So this is important because it's going to tell you about the nerve, kind of the nerve root patterns of it. So, and also different diseases and different pathologies radiate to certain areas. For example, appendicitis starts in the umbilicus and then goes to the right iliac fossa. Chest pain classically goes to the left shoulder, neck, or between the shoulder blades. So again, this is now helping to zone in on those differential diagnoses. So you've asked the patient where it is, what's the onset, what's the timing, what's the character, and radiation is just another tool that's going to further zone in on your differential diagnosis to your first diagnosis. Associated symptoms. So by this point, you should have a few differential diagnoses in mind. One main diagnosis and two differentials is what I would always suggest and what's usually expected in your OSCEs. So in order to ask associated symptoms in your Socrates, you have to have an idea about what your differential diagnosis is. For example, if you're worried about an MI, you're going to ask them if they were clammy, having palpitations, felt short of breath, and were they nauseated. If you're worried about migraines, you're going to ask about photophobia, phonophobia, vision changes, nausea, and vomiting. This very much depends on that knowledge that you consolidated in your first and second year, where you learned the diagnosis first and the different symptoms associated to that. Now you have a patient and you have the symptoms, and you need to elicit anything else that might be associated. So I'm going to skip timing because we've already done that with onset, and we're going to go to exacerbating factors. Another reason I like putting timing with onset is because I find from associated symptoms, exacerbating factors follow on quite nicely. So we've now established what other symptoms the patient has. And I just want to come back to that chest pain. Does anything particular make it worse or make it better? So you have to ask about exacerbating and relieving factors. And this again depends on your differential diagnosis. For example, if you're worried about a gastritis, you're going to ask about, is it worse when you're drinking alcohol, having caffeine, or eating spicy food? If you think the chest pain is a chest wall pain and more muscular, you're going to ask, is it worse on movement? Now, initially, when you ask these questions, make sure again it's open ended. Your patient will be prepared to answer them. However, if they do need some help, maybe they say, well, what do you mean by something makes it worse? Or what sort of things, sometimes they prompt you and say, what sort of things do you mean, doctor? And you need to be specific. So you have to have your differential diagnosis in mind by this point. Along with exacerbating factors, you're going to ask about relieving factors. So does anything make your gastritis better, for example? And they're going to say, yes, Gaviscon helps, or an antacid. Again, this feeds into the differential that you have in mind and helps zone in even further. And finally, severity. Now, a good way to get those extra points in your OSCE is to ask about severity and to show empathy here, which is the most important. Doctors must show empathy, and being able to show that in an OSCE in the early years will set you apart from other students. So if the patient says, Doc, my pain is 9 out of 10, you need to say, I'm so sorry to hear that. After I'm done, just bear with me for a couple of more minutes and I'll go and try and arrange for you to have some painkillers. Is that okay? Being able to empathize with the patient like that puts them at ease and shows that you're reacting to them. You're not just taking a tick box of questions. You're listening to them, realizing that they're in pain, and you're going to act on that. So whenever the patient says they're in pain and you go through your Socrates and you reach severity, please remember to offer painkillers. So this is our Socrates assessment. Now this will lead quite nicely to the next lecture, which is when we're going to talk about different causes of head pain. So we're going to meet Tom, who's going to be our assistant, and we're going through all the different causes of head pain. So all of those will be in this Socrates format, and you will need this lecture in order to proceed on to the next one. Thank you.